I think we can get started. For those of you who don't know me, I'm Kristyn Hodgdon, co-founder of Rescripted, and I'm joined today by Brett Pine, president of Braun Pharmacare, and we're going to be talking about IVF medications. So thank you, Brett, for your time today and for joining us.
Oh, my pleasure. Thanks for having me.
I think IVF meds are such a daunting aspect of the journey for so many. You know, you get that big, I remember getting that big box of medication, and I don't know who made the error, the nurse or the pharmacist, but I ended up getting like 10 too many boxes of Menopur.
Oh my goodness.
And so the box was like extra big and heavy, and I was like, wait, all of this is supposed to happen in the next 2 weeks. But, you know, no matter whether you get too many meds or not, I think it's just like, okay, what gets stored in the fridge? What do I do now? How do I even inject myself? I'm scared of needles. Like, there's just so many things that go into it. So we kind of wanted to talk about some of the more common IVF medications specifically today. And sort of how they work for your cycle, because I think if someone's starting IVF for the first time, they're just looking at all those medications and thinking, you know, how do they all work together? Like, why are there so many? So just, I guess, jumping right in, the most commonly referred to IVF meds are the stims, and that is what helps stimulate egg production prior to an egg retrieval. So can you talk a little bit about the different type of stim medications, like Gonal-f and Follistim?
Absolutely. And I want to take one quick sec to say that it is a daunting process, but recognize any of us, and I've gone through this with my wife as well, and many other people have, it's for a very good reason. So take a breath with the daunting process. It's for a great reason. It's going to be a little bit of a journey, but we're working towards a great goal. So I want to just preface with that, all the optimism we can keep is always great. Yeah, stim meds seem to be, that more fashionable, more popular, commonly discussed part of IVF. The most commonly, there's really only three main common ones. Two of them are what we call FSH, or follicle stimulating hormones. Those would be either Follistim or Gonal-f. There's also a product which I'm sure a lot of people have heard of called Menopur. We normally refer to that more as an LH, or luteinizing hormone, although there are protocols out there that use it as the stim, pure stim, or as the follicle stimulating hormone per se. So really the way it works is during the stimulation process, on average, you'll see this go for 8 to 12 days. And during those 8 to 12 days, you would use either Follistim or Gonal-f. They're two different manufacturers of very similar products. And Menopur is going to be the coinciding protocol. And coinciding meaning when you're prescribed those stimulation medications, I think it's fair to say 98 or 99% of the time, if you're prescribed Follistim, you'll be prescribed Menopur with it. If you're prescribed Gonal-f, you're going to be prescribed Menopur with that as well. And I could go into a little more about it if you want, but those are really the two main names, and how long you'll be using them, and why, when they're being used together.
Yeah, thanks for explaining the Menopur thing, because I was always curious about why they had to add Menopur on top of the Gonal-f or the Follistim. So that's really helpful. What about low dose HCG? I know that kind of falls into that stim period as well sometimes.
Yeah, so Fairing might not like this, but I would put it like this. Low dose HCG is the closest relative of function that would mimic Menopur. So let's be honest, there's some economics involved with this, and Menopur is a great product. It is a one-of-a-kind product. It's amazing. That's why it's used with literally, I said 99%, it's almost 100% all protocols. There are a number of clinics, and not one or two, but there are a decent amount of clinics that choose to use low-dose HCG in place of Menopur. It is extraordinarily diluted, low dosage forms of HCG compared to when you use HCG as a trigger. And it's going to mimic some functions, obviously on a different chemical reaction, but on the economic level, whereas whatever we would potentially pay for Menopur, the low-dose HCG protocol would be a percentage of the cost from an economic standpoint. That doesn't mean we should discount the importance of Menopur or discount the importance when, if a clinician says, listen, I use Menopur. Oh, I heard about low dose HCG. Yes, those protocols are out there. We have full support of the clinicians using them, but this is what I prefer. So there's not saying that one is bad, one is good, but there are different protocols and preferences that are available at the clinic setting.
Got it. And so for those who are curious, can gonal F and follistim sort of be used interchangeably? Like if, how does that work?
That's a great question. So the short answer, yes. There's two different ways to look at it. Dr. A always prefers follistim. However, patient B said, listen, I've used gonal F before, it worked for me, or hey, I think that I have an economic advantage on one versus the other. I would be hard pressed to believe, and nor do we see a clinician say, I'm sorry, but you can't use that. And here's why. From a therapeutic, efficacious, similar outcome, you're going to have almost the exact same outcome. I think there's studies out there that you could find the most minute percentage points different, but it's not going to say one's better than the other. They're absolutely interchangeable to the point of this. We have seen times where a patient is using, let's say follistim. They're on their 8th day of follistim. They run out. For some reason, they can't get more. They can't find or reach who they need to reach to. It's late at night, but they found that gonal F is available. There are some clinics that won't do this, but we've seen people mid-cycle switch from follistim to gonal or gonal to follistim. Is that the norm? No. Is that the ideal situation? No. Is it going to cause harm? Unlikely. So that's how interchangeable they can be, but there's definitively clinicians that'd be like, listen, that's just not what I'm comfortable with or accustomed to. But in a pinch, it wouldn't be something where, I'd put it this way, I'd let my wife do that if that was a pinch that we got into in an urgent situation.
Okay, that's good to know. I mean, I think sometimes people just, are in a pinch situation where they're, they need to borrow from a friend because they ran out or who knows, so that's really good to know. So what about omnitrope? I hadn't heard of that before, but I read that some IVF protocols include it to help improve the quality of eggs. How does that come in?
Yeah, so omnitrope, there's a couple different growth hormones on the market, but omnitrope, we call HGH, it's a human growth hormone. Obviously, there's other purposes for it, but about 10 years ago, we started to see it come on the scene initially, maybe a little bit more, and it gained popularity. First, let me just say that if a patient's protocol involves or does not involve omnitrope, it's not a good or bad thing. It's a little bit case-to-case dependent and preference dependent. The point here is omnitrope or growth hormone has the ability to increase pregnancy rates in some cases, increase egg quality, but not necessarily increase egg production. So quality versus production. This is a very, maybe not even PC way to put it, but it's almost like a turbo boost. We're hitting a turbo boost button where, listen, in one respect, stimulation medications is a turbo boost. We really want these eggs to ripen to a certain maturation and certain size. We're going to give some stimulation to get them there and help push our body to get to that point. In some cases, depending on how a woman responds, maybe she's a low responder, maybe we want an extra little push on top of the stimulation medications. And that's why growth hormone has gotten a little popular, because quite frankly, not from an actual age development where we're getting older, but sometimes as we get older for fertility, we need a little extra stim to get our bodies to where we need to go. And now there's an extra little boost on the side that is in the form of growth hormone. And omnitrope is, well, one of the reasons we see omnitrope is a little more popular as comparative to the other growth hormone on the market, one of the other popular ones, it's a little more economical in comparison. It's a refrigerated product. It's subcutaneous, so it's in the abdomen with a little bit shorter and thinner needle, which we all like, obviously, for the proper reasons. But we've seen it gain a lot of popularity. Again, if for some reason someone works with a clinician that isn't using it or doesn't like to use it, not a bad thing. It's just differentiation of preference.
Okay. And all of the stim hormones are pretty much subcutaneous, correct?
Yes, stimulation medications, sometimes BMI can change that necessity of how we're going to inject. But yes, follistim, gonal F by default are typically subcutaneous. They're used from a pen device that you actually can dial your dose, and then it preps it and primes it for that dose, and you inject. Menopur is a medication that's subcutaneous as well, and all human growth hormone is used subcutaneous.
Got it. Okay. Those are the less scary, the less scary injections, which is good that those ones are what you start with because it's like an entry point. And then, I just wanted to touch on before we move on to sort of the next stage of medications. What are some of the common side effects of these IVF medications? And what's an example of a side effect that you should maybe call your nurse about?
Yeah, that's fair. So first and foremost, I think it's fair to say on medication in general and any medication we talk about from an incidence of side effect, two things are important. One, headache and nausea are always potential, right? It's always out there. And two, before I go into the side effects, I want to mention this, that because these side effects are available and potential incidents doesn't necessarily mean they will happen. Some seem lesser of either a potential or lesser of invasive reaction, but mentioning them does not necessarily mean they will happen. I just want to preface that because my wife hears it. If you might hear, you might smell burning feathers. I think I smell burning feathers. So obviously that's not a real side effect. All I'm saying is because it's possible doesn't mean it's actual. So headache, nausea are pretty normal. Mood swings, because we are injecting hormones into our body, that's possible. I do think spouses like myself can force mood swings myself as well as a side effect. Cramping and bloating are definitively possible. Rash and itching, breast tenderness. I think if you start having extreme rash and extreme itching, that is definitely a good example of something that you can call out to your nurse in case you have either an allergy you're not familiar with or an allergy we didn't let someone know for allergenic response. Obviously, if you start getting rash or allergic reaction to the point of any breathing issues, you would always want to let someone know right away. So I think that's a good one to call out. I do want to say for the final time, again, just because there's potential doesn't mean necessity of happening.
Awesome. And I kind of wanted to touch on the fact that you can also call your pharmacist, correct? If you have any medication questions. I know Braun is a great resource for your patients.
So I think, yes, that obviously, we all have our own nurses and clinicians we work with. As a pharmacy, it is our job to know about all forms of medications across all spectrums, how they might interact with how they might interact with other medications. And part of our job as a pharmacy, our pharmacists have to be available to consult. Braun, for example, we have a 24-hour pharmacist available. Once we close, we have an emergency contact pharmacist that's always available. We have a fertility nurse on hand that works for us too, that can do consults and unboxing. So no matter what pharmacy you work with, they're an amazing resource, and by default, they have information that's valuable and can give feedback in the form of consultation, just like a nurse. Never hesitate to call your nurse, but I think you should never hesitate to call over to your pharmacy as well. It's a very good point.
Absolutely. And I never thought to call my fertility pharmacy with questions. So I think it's important for people to know that that's a resource for them too throughout their cycle if they can't reach their clinic. So on top of stim meds, around day 5 or so of an IVF cycle, a patient usually starts what is known as an antagonist to prevent premature ovulation, because you're growing your eggs and then you don't want to ovulate too early prior to the egg retrieval. So medications like that include ganirelix, cetrotide, and leuprolide. And can you just talk a little bit about, those 3 medications? Are they all the same? Are they different? Would a patient just take one or all 3?
Yeah, you have some great questions. So I think I'll liken this first part. Ganirelix and cetrotide are interchangeable, and here's the liken. I mentioned that Foals and Gonal-f are interchangeable. Ganirelix and cetrotide are interchangeable, in so much that where Foalstim is made by Merck and now Organon, and Gonal is by Serrano, Ganirelix is made by Merck and Organon, and cetrotide is by Serrano. So the 2 different manufacturers have, for lack of better description, competing products, but essentially they're mimicked products by different manufacturer, administered the same. Mixing can come into play. So here's the short answer is Ganirelix and cetrotide are interchangeable. We would not use them together, but your clinician or the patient will be choosing, okay, I'm doing Ganirelix, it's a 5 to 7 day protocol, or I'm doing cetrotide, 5 to 7 day protocol. One thing to note, similar to what I mentioned with Foalstim or Ganirelix, gosh forbid we run out, I'm going to blame the husband, because normally we're the ones that make mistakes, is I dropped one, I broke it, I stepped on it, I threw it out, I lost it, whatever it is. And I'm in desperation. It's 10 o'clock at night. I can't reach anywhere. And my friend has an extra Cetrotide and I've been taking Ganirelix. I would feel comfortable to say that the majority of the nurses would be like, I would just take that to stay on protocol. You have your antagonist, go. So that's one thing to say. Obviously not our first preference, but I just wanted to let you know as an example of interchangeability. So one thing, and I think you mentioned this a little bit, so Ganirelix and Cetrotide, the goal there is to stop the eggs from being released too early, so we have enough time to properly grow, right? Now, Leuprolide, which would, in general, is not typically used in conjunction. I have seen some protocols where not same day, they might change over to Leuprolide for whatever the reasons they would prefer, but in general, these antagonists, you pick one, you go with it. And we're sometimes known as suppressants because we're suppressing our body from releasing these eggs too early. So our eggs have plenty of time to actually grow, right? Leuprolide works on a little bit different chemical action, where Leuprolide is improving the number and quality of eggs available for fertilization. So a little bit different than stopping and restricting, so we have time. They're also being a suppressant, but it's improving the number and quality of the eggs available for fertilization.
Okay, but that's not always included in a protocol, correct?
Not always, no.
Okay.
Again, some of them are case to case dependent, and some of them are dependent on where our body is and how our body has reacted, and what some of our baseline levels in testing has shown of what we would respond to a little bit better.
Right, everything's so personalized with IVF. It's definitely not one size fits all.
Yes.
And is Leuprolide the same thing as Lupron, or it's known as Lupron?
Yes.
Okay.
So Lupron was the brand name of Leuprolide. It no longer exists. Only the generic Leuprolide 2-week kit is now available. And doesn't mean it's a 2-week kit, like you have to use it as a 2-week kit, but more often than not, you will use it up to that time. And my dog is saying hello in the background. I apologize.
Hi, puppy. Love the work from home pet situation.
Yep.
So, and are these injections also subcutaneous?
Yes. So, one thing on administration, first and foremost, Ganirelix, Cetrotide, and Leuprolide are all subcutaneous injections, meaning in the abdomen. One thing a little bit different on Ganirelix versus Cetrotide is, although I said they're interchangeable, Ganirelix is a room temperature storage pre-filled syringe, where Cetrotide is a refrigerated product that does need to be reconstituted. Reconstituted means mixed. Mixed meaning normally with a sterile bacteriostatic water or a 0.9% sodium chloride. Please note that anytime reconstitution is needed or these mixing protocols, the product comes with this water or this diluent that you need. So it's not a matter of, are they going to ship it to me separately? Do I need to go out into the world and find this? If there's a reconstitution or a dilution needed, it will come with the product, typically by default from the manufacturer in the same packaging.
Okay. That makes sense. Okay. And then, so we're closer and closer to egg retrieval. We've done our antagonist medication. And then we have to trigger, within 36 hours of retrieval. So Lupron or Leuprolide can also be used as a trigger, correct?
That's correct. Yeah. So, let's get into the basics here. So, Pregnil, or HCG, I'll call it. HCG is one of the triggers. Avidril is another trigger. HCG will constitute as either Pregnil, which is a 10,000 unit trigger vial, or Novril, which now exists as 5,000 units. Leuprolide triggers are different. It's a different product. And I will liken it not exactly to Menopur, but I'll call it a dual protocol. And dual protocol means that now it's time to trigger. After stimulation, we want to trigger because we want to control and force the body to ovulate. We need to ovulate so we know when we need to fertilize the egg, creates the best opportunity, time for intercourse to do so. What they'll do is, so in IVF, more often than not, they use HCG. And in a frozen embryo transfer, more often than not, they use Avidril. Again, does that mean if your clinician uses something different, is there a problem? No, I'm just talking about normal protocols and what we see on average. Now, what will happen with this trigger is some clinicians, and in about the past maybe 5 to 7 years, it's gotten very, very popular, meaning normal. Leuprolide triggers have been introduced where we have now taken our HCG trigger, and 24 hours later, we're going to do our second or dual trigger with Leuprolide. and it's going to be used in conjunction with the original trigger. It's typically not used on its own, and it's just something that has gained popularity. And in some cases, we'll see an HCG trigger, followed by a Lupron trigger, followed by another Lupron trigger. So it's really gained popularity. We see it in many, many clinics. Again, it's not a requirement. So if your clinician doesn't do it, it's not a good or bad thing. But if they do it, it's something that we've seen has become a little normal.
Okay. Yeah, I think I knew that there could be up to 3 trigger shots.
And trigger, by the way, it's called trigger because we're triggering the body to ovulate. So that's why we all refer to it.
Yeah. And it's so interesting how it has to be at such a specific time. I remember saying to my nurse, like, wait, what if I'm on the Long Island Railroad and like, that's the time I have to trigger? She's like, well, you just have to go in the disgusting train bathroom and trigger.
Yes. And normally we don't have only minutes. So, there are times where even though we're on that train, we will find time. And let's be honest, if we're minutes past something or close to that time frame, we still have every availability for success.
That's really good to know. So following the egg retrieval, if people are lucky enough to have healthy embryos after their retrieval, a lot of times we do frozen embryo transfers. So I know there's obviously a medication protocol that is involved with that. So estrogen is typically used for like up to 3 weeks leading up to a frozen embryo transfer. And that is just in pill form, correct?
Yes, but there's actually 3 forms of estrogen available. So the pill
Okay.
form is called, the brand name is Estrace. Estradiol is the generic. Almost everyone uses the generic and has potential to be used either orally or vaginally. The secondary source is an injectable source. It's called estradiol valerate, or the brand name is Delestergen. That is an IM injection, just to be honest with everybody. So not in the abdomen. And then the third form is in the form of topical patches. They could be called Vivel Dot. They could be called Minivel. And again, more often than not, the generic is dispensed, especially for economics, but efficaciously similar. Those are estradiol 0.1 milligram patches. They're topically used, and on average, you wear them for 48 hours at a time, and then you change them out.
Yes, I've heard of estrogen patches. I didn't realize there were estrogen injections. Are those every day?
Normally, they're every 3 days, and they're for a short duration, so a couple weeks. That's a little bit case to case dependent, but there are certain level values. As pharmacy, we don't get into like, this is exactly the range you need to be in. We normally get someone's in this range, so we need this injection. You know what I mean? But in general, all 3 estrogen protocols are very great. They're very good response, but they're used very interchangeably, very differently. I mean, so if you have a Delestergen or estradiol valerate injection every 3 days, or you're taking estradiol tablets, you'll take those tablets up to 3 times a day for 30 days, where the other one is once every 3 days for 15 days. So it's very different and unique in the dosing pattern, but they all have very specific utilization that create estrogen level change.
Got it. Yeah, we have support groups every other Thursday night that I lead, and we are actually having the conversation. I was telling the girls that I needed to buy a pill box, like an AM, PM pill box, but it didn't help with those midday estrogen tablets. It was like, wait, I need like a midday little pouch for my, I had to set like 8 iPhone reminders. But yeah, I mean, it's a trade-off, I guess. It's like the pill can be easier than an injection, but it's like, you just have to remember.
And I'll be honest, as a male, I don't take for granted, especially because my wife went through this and we see this from the pharmacy, how much that, women do more than men to try to create, the success of this journey. So as a pharmacy, we understand the roller coaster that's involved, but when you talk about a roller coaster going up and down, that means there's ups too. And although we go through a socioeconomic, personal, professional journey on this, the journey is really important, because I think the best thing about fertility is the fact that if we cannot naturally conceive, we have an amazing next plan of action to create the success we're trying to do ultimately anyways.
Absolutely. And then so progesterone. And to that point, IVF can be such a great option to, if you do want multiple children down the road. We just recently did a frozen embryo transfer of one of our remaining embryos that we created 4 years ago. That's science is so cool.
That's amazing.
And I do make my husband do all the shots because I give him that job. But the progesterone, I think, scares him more than it even scares me because the needle is so big. So can you just talk a little bit about the progesterone injections and what their purpose is?
First and foremost, everything you just said about it is very normal, very standard. And the men should be involved if there's a male, or it doesn't matter, whoever the spouse is, get them involved. We need to all be a part of this process. Mm-hmm. It is an IM injection. It's typically given in the upper hindquarters, in the buttocks. The beauty there is, I don't know about everyone else, I have some extra skin back there. And normally it's a good place for absorption and whatnot. What we do is, first and foremost, part of the scary thing is the first needle we use to withdraw the progesterone is a very big, thick needle. And the reason being is progesterone is viscous. It's a viscous oil, and the larger the hole on the needle or gauge of the needle, the quicker we could withdraw it. Now, to settle a little anxiety that I'm causing, we then switch that needle out to a smaller gauge, but still an IM length needle. So that way we could get through the dermal layers. And instead of a sub-Q injection, we're doing intramuscular, not subcutaneous. So yes, we switched to a bit of a thinner and smaller hole needle. We're going to do this progesterone support for about 12 weeks. What's really important about progesterone support to going into past administration, and so we withdraw, we inject, what's the point of doing all this? And what's the point of continuing to do progesterone after we've gone through this therapy? Well, we want to be proactive and preventative. And anyone in this group, we might consider them a higher risk group than other people for preterm labor and premature birth. So this progesterone support, with the beauty and engagement and goal of this, is to lower the incidence and reduce the risk of premature birth, preterm labor, early contractions, things of that nature. So that's why we're going to do it all the way through the first 12 weeks to help create that lowered incidence. And in certain times, depending on how your body responds and your levels, and this is not a bad thing, they might go a little further. There are other avenues of progesterone as well, but you were asking about intramuscular IM progesterone. So that's that. But there are other avenues to take progesterone to increase your levels.
Right, the suppositories, and is there another option or?
So there's a suppository called endometrin. That'd be taken anywhere from 2 to 3 times a day. I know that's a lot. We do work and we do need to find time for our medication. And as you said, it doesn't always work with the pill box in the midday. Mm-hmm. There's also something called crinone, which is a vaginal gel. So instead of a suppository, the suppository kind of looks like, it's like an overgrown Tylenol. It just is a big tablet and absorbs. The goal of it is to break down. And then crinone is a gel versus it acts like a suppository, but it's a vaginal gel that gets applied. And due to it being a gel, that uses that vehicle to break down as well. There's always potential for any suppository or gel to be discharged, totally normal. So if any of that happens, there's nothing wrong. It's just anything that wasn't absorbed comes back out, very natural.
Yeah, I think the worst part about progesterone is not the size of the needle, but the fact that the side effects can mimic pregnancy symptoms.
Yes.
So it's a catch-22 because you're like, wait, I'm feeling something. Oh wait, no, it's just the progesterone.
Yeah. And one thing to note, because we've spoken about side effects before. 2 things here. One, a couple just general, very normal side effects. Injection site pain is probably the most normal, right? Mm-hmm. Sometimes people, whether you're allergic or not, you can get what we call welts or little raised areas. One thing that I always suggest, I don't care if it's sub-Q or intramuscular, let's pretend we give an injection on your left butt cheek today. Let's go to the right on the next one. Let's give the pin cushion some time to relax. So I don't care if you're going in your abdomen, it was a really easy shot. You're like, gosh, this was a piece of cake. Or maybe you're a little more sensitive and you're like, that was not a piece of cake. Let's give that region some time to heal. It's obviously a little pinprick, but that's still creating a little hole. Let's go to the other side. And when we come back, if you actually notice where you were, move an inch to the left or the right. Mm-hmm. As a gauge from when you do sub-Q, I always tell people, here's your belly button. Go 2 inches to the left or the right, go an inch to the left or the right. And if we went 2 inches to the left, let's go 2 inches to the right. If you went 2 inches last time, maybe go 3 or 1. And that's how you can kind of create, you don't want to keep repeating the same point. We're doing these injections for an extremely important reason, right? But let's try to make this at least some comfort that's possible. From a comfort range, there is medieval ways and medicational ways to lower any discomfort. Medieval way, put an ice cube on the region exactly where you're going to inject for 1 to 2 minutes before. We're going to cold numb that region, inject through that region, and you should, by default, from freezing that area, make it feel, less discomfort injecting. Medication-wise, there's something called Cinera patches. They're a lidocaine and tetracaine, potentially benzocaine as well, base. So you put that on, I think, 15 to 30 minutes before injection. It literally numbs that region, and then you give an IM injection through there. There's actually vouchers out there that could discount it. So there's some opportunities there. And then one last thing, and I need to stop on progesterone, is some people are allergic, manufactured progesterone is a sesame seed.
I was going to ask about that. Okay.
All right, we're on the wavelength, right? Let's be honest, seeds, nuts, things of that nature are probably one of the most common allergies or sensitivities. The manufactured progesterone on the market is a sesame seed oil base. So the medium and vehicles in oil that is derived from sesame oil as a suspending agent. We might already know in advance that we have allergies to this. If we do, there's an option. And I'll give you the option in a minute. But one other thing is you might also not be allergic, but you could have sensitivity. And sensitivity could lead to this maybe extra discomfort, maybe welts or hives or something of the nature. And then here's the backup plan here. There's a compounded progesterone product, which is the exact same volume. It's 10 mLs. It's the same strength. It's 50 mg per ml, and it's suspended in a different medium. It's called ethyl oleate. Ethyl oleate's only available at USP 800 sterile pharmacies that do this compounding themselves. Braun does make ethyl oleate ourselves. We have a very large population of patients who either know up front they've reacted to sesame oil, they know up front they have sensitivity or allergies to nuts or seeds, or seed, they just have had extreme discomfort for whatever reason to sesame oil, and they electively use ethyl oleate. So ethyl oleate is a less viscous product, so it's easier to draw up, and you can use a slightly smaller gauge needle to inject, so a little bit more comfort there. And it creates a much, much lower to almost zero allergenic response. It wouldn't be fair to say 0%, but much lower. Braun actually offers a 50 milligram and 100 milligram in case you have a protocol that injects a little more than normal. But overall, same therapeutic event, outcome, efficaciously similar, creates a lower incidence of side effects.
That's great to know. Well, this has been so helpful. Before we wrap up, I kind of wanted to, just because we know IVF meds are expensive, can you talk for a second about, some of the discount programs that are out there and how people might be able to save?
I think that's a great point. So yes, there are some economical challenges sometimes incorporated in this, but we all know that we're doing this, like I said earlier, for the greatest reason possible. We're trying to either build our family or further grow our family. There's a number of programs available. Our example with Braun is a Merck or Organon pharmacy, which means that we have discount programs associated with Follistatin, Ganirelix, and Pregno. The program is called Reunite RX. These discounts are available for free. You get them by default. You have to do no action other than work with our pharmacy to do so. But just to be completely unbiased, any pharmacy that is a Reunite or Merck or Organon pharmacy, these discounts are available to you. And the pharmacy will offer them to you upfront at no charge, at no work. What this will do is from a non-fertility pharmacy or certain, not even going to specify, but there are certain pharmacies that either don't have contracts in place or not true fertility pharmacies, they won't be able to offer these discounts because they don't have contracts with the manufacturers. These contracts allow pharmacies like ourselves to sell products at 50 to 60% under cost. And then we work with the manufacturers to rebate back to where we need to be. There's also another program through Fairing. They've sometimes called it the Fairing Network price or the Fairing Heart price. What this does is it discounts Menopur, Endometrium, and Novorol. And this again is a free discount plan that's available to all patients using them. Just to be completely fair and unbiased, although I'm a Merck and Organon pharmacy, Serrano pharmacies have what's called, they have a Serrano discount on Gonal-F, Cetrotide, and Avidrome. So some competing products that do some similar goals and goal structure from a medication standpoint. Those are free as well. It gets processed through ESI, and these pharmacies offer it. Now, there is one next level of discounts available. So I mentioned Reunite. Reunite RX is a discount program that's out there. Reunite also offers a couple different sub discounts, meaning they're additive. So if Braun offers a product at a heavily discounted price, these programs I'm about to mention can further discount based. Some are income dependent, some are not. The quick ones I want to mention is there's a veteran discount that's available through Reunite RX. So pharmacies like ourselves, if you are active or retired military or any veteran armed forces, whether it is either spouse, you get an automatic 25% discount on Merck Organon associated products, Follistim, Ganirelix, and Pregno by default. You just need to sign up through their portal. It's reuniterx.com. It's right on the front. It takes 5 minutes to register. And by default, everything that we would offer, or Merck Pharmacy or Organon Pharmacy that uses Reunite, will, on top of your discount, automatically apply 25%. So that's one of them. The second one is called Reunite Assist. Reunite Assist is an income dependent property where, again, through www.reuniterx.com, you can apply, and based on some demographic features, your application, some income levels, you can get anywhere from 5% to 75% off your order on top of the discounts. So, I mean, we're talking thousands of dollars. All you need to do is apply. They will respond typically within 24 hours. A pharmacy like Braun can actually aid in this process to try to get that turnaround quicker, because sometimes, as we know, protocol is extremely time sensitive and urgent. And again, to stay fair and unbiased, Serrano pharmacies have something called Compassionate Care. It works the same way as Reunite Assist. I don't know the website, but you can look up Compassionate Care. And if you apply based on income levels, they can decide to give you 25 or 50 or 75% off your products. So there's avenues out there. And the last one is, gosh forbid, we need to be working with an oncologist. There is oncofertility and fertility preservation discounts that are available. The ones that are related to Organon and Merck products, you again go through the website, you can apply for it, and you get eligibility actually to have 100% coverage on a round of the Organon products. So it's certain quantities of the 3 medications, but it's showing that, listen, these are urgent, these are necessary, these are fertility preservation. Let's preserve, our follicles, our eggs, before we do any medications that could potentially change the dynamic of those. And again, through that portal, you have eligibility to get some additional discounts. The last one that's available, and then I need to take a breath of fresh air here on this call so I could breathe, is Ferring has a program that a pharmacy could help you apply, or you could apply on your own, that is for egg freezing. And if you apply to Ferring's program, and you could go on their site, and it's available, there's an egg freezing component there that I believe if you buy 20 or 25 vials of Menopur, you get an extra 25% discount on the discounts already available, to make those available to you at a significantly reduced price. So a lot of information. Our website could help detail this. Reunite RX can detail this. Ferring can detail this. But I personally always think it's worth taking 5 or 10 minutes out of our day to get a potential for a discount. And every dollar we save now might save $1 towards diapers in the future. So
absolutely,
I think it's important to detail all of them. I apologize for all that information, but there's a number out there, and it's better to educate.
I think it's so important because, clinics don't really advertise those discount programs when they're, writing your scripts. And so, yeah, this will be saved on our YouTube channel, and hopefully it helps a lot of people, get the discounts that they deserve. So thank you, Brett. This has been amazing. And I learned so much, even though I've been through IVF and myself.
Thank you.
I think it will help a lot of people. So I appreciate your time.
My pleasure. I wish everyone nothing but the best of luck. All, Rescripted or Braun, we're all a resource here. Use us to the best that we can help everyone to go through their journey successfully.
Absolutely. Well, have a great rest of your day. Thanks again.
Thank you. You too. Take care.
Bye.
Bye.